In this video, I'm going to explain my approach to treating depression, also known as unipolar depression or major depressive disorder. Before your first visit, you'll complete a few rating scales. These ask about depression, anxiety, sleep, and more. These are super helpful for us to monitor progress over time, because 3 months from now, when you're feeling back to normal, it's often very difficult to remember how you felt back then. In fact, using rating scale to monitor progress over time makes you 1.8 times more likely to get back to normal, which is called remission. So firstly, when I'm evaluating depression, I often like to look for an organic cause of depression with lab work. Some of these labs include checking a thyroid level for high or low thyroid, hemoglobin for low levels, which is called anemia, glucose for high levels, which can be diabetes, or for low glucose, electrolytes for high levels of sodium and potassium, kidney function, liver function, vitamin D for low vitamin D, vitamin B12 and vitamin D9 for low levels, homocysteine, which is a marker of inflammation, which is toxic to the body if it's too high, and homocysteine can also help diagnose a hidden B12 deficiency if the B12 level is in the low normal range. Testosterone for males with low levels, hemoglobin A1C, which looks at the blood glucose level over a 3-month period, and a lipid panel to check for LDL cholesterol, HDL cholesterol, and triglycerides. Several of those labs are to get a baseline, such as the lipid panel, the glucose, the kidney, and liver. But those other tests are to look for actual causes of depression. If there are abnormalities in the thyroid, B12, B9, vitamin D, or testosterone, those can all actually cause depression, and when those are corrected, they can get rid of the depression. So it's super important to check those. Now, if all the labs are normal and the depression is mild, we may consider a several-month period of therapy only, and sometimes that's all you need. That can be first line. If depression is moderate to severe, or if you prefer starting medication, then we have several options. But before starting treatment, something you might consider is pharmacogenomic testing. This testing looks at your genes and how your body metabolizes certain psychiatric medications. And a meta-analysis has shown that using this genetic testing to guide treatment actually makes it 1.8 times more likely to get you feeling back to normal. Now, regardless of whether we start on medication or not, everyone with depression should be taking a fish oil omega-3 supplement, 1 to 2 grams of omega-3 EPA daily. And the reason why is because there's evidence to support that it's helpful with depression, and there's very little side effects or risks to it. Now, moving on to the medications, let's assume you haven't done any pharmacogenetic testing. Here are some good starting options. 2 good starting options if you have depression and also anxiety with it would be escitalopram, also known as Lexapro, or sertraline, also known as Zoloft. These usually work well, have a low side effect profile, and don't usually interact with many other medications. If you don't have anxiety, or if you're having problems with attention, like ADHD, another option we might consider would be bupropion, also known as Wellbutrin. Bupropion actually has the most favorable side effect profile out of any of the medications I've mentioned or I'm going to mention. Bupropion specifically does not cause any weight gain, and it does not cause any sexual dysfunction. Sexual dysfunction meaning decreased libido, difficulty with orgasm, things of that nature. To see if any of these medications work, we usually need to titrate up to the usual dose range, meaning the range that works well for most people, and continue at that dose usually for about 4 to 8 weeks. So with most of these medications, it's important to remember that they don't work right away, and they take a little bit of time to start working. On the other hand, side effects usually start right away when you start the medication. But the good news is, once the medicine starts working in 4 to 8 weeks, that's usually when the side effects go away as well, if you happen to have any at all. Some people don't have any side effects. If we've given the medication a good trial and it hasn't worked at all, then we'll usually switch to a medicine with a different mechanism of action or a different way that is metabolized. Lexapro and Zoloft, which we mentioned earlier, are serotonin reuptake inhibitors, which increase serotonin. Bupropion is a norepinephrine reuptake inhibitor, mainly, which increases norepinephrine. That's important to remember when we're discussing these next 3 options. The first option is venlafaxine, also known as Effexor, and this is a serotonin norepinephrine reuptake inhibitor, so it increases both serotonin and norepinephrine. Vortioxetine is number 2, and it's also known as Trintellix. It's also a serotonin reuptake inhibitor, but in addition to that, it has several other complex effects on serotonin as well. Just two of those effects are that it blocks 5-HT3 and 5-HT7, both of which can help with depression. And option number 3 that we might consider is Auvelity, which is a combination of bupropion, which we mentioned earlier, but it's combined with another medicine called dextromethorphan. And these two work together quite smoothly to boost one another. Auvelity works by a different mechanism than anything we've described previously. It's an NMDA receptor blocker. Blocking NMDA is a complex mechanism, but ultimately it results in increased glutamate levels, which then downstream helps increase levels of BDNF, also known as brain-derived neurotropic factor, which is very important in depression. Now, moving backwards, if we tried one of those first medicines, Lexapro, Zoloft, or bupropion, and it did work a little bit, then we might consider keeping one of those on board because we got some benefit from it, and then adding something in addition. We call that an augmenter. 3 good augmenters that we may consider include Cytomel, also known as T3, which is a thyroid hormone. High-dose methylated folate. This is under a brand name Deplin. However, we do not always have to get that brand name. There are other generic options as well. And lastly, low-dose lithium. If you recall from earlier when we talked about blood work, we actually checked for the thyroid levels, and we checked for B9, which is what folate is. And if those didn't work as augmenters, then we might consider 3 other options. The first option is a broad-spectrum psychotropic that blocks both dopamine and certain serotonin transmitters that we want to block. These broad-spectrum psychotropics are called Seroquel, also known as quetiapine, or aripiprazole, also known as Abilify. And there are many others. Those are just 2. Now, Abilify and Seroquel are very effective as augmenters for depression. However, they carry a big risk, and this is something I'll talk about more in a different video. These broad-spectrum psychotropic medications, because they block dopamine, carry the risk of tardive dyskinesia, which is an uncontrollable movement disorder that could potentially be permanent with using such medications. So it's important to understand those risks, even though they are very effective for depression. Now, another option we might consider would be switching classes again to something called a tricyclic antidepressant known as nortriptyline. And another option we might consider would again be switching classes to another medication with a different mechanism known as selegiline, which is an MAOI, a monoamine oxidase inhibitor, which increases all of the neurotransmitters we've mentioned. It increases dopamine, norepinephrine, and serotonin. And of course, whenever we're talking about treatment resistance, which by definition means 2 failed medication trials, we always have to consider transcranial magnetic stimulation, TMS, and intranasal ketamine, which goes under the brand name Spravato. Both of these can be super helpful and can work for treatment-resistant cases. One extra benefit of ketamine is that it works very quickly as the first dose. And to explain a little bit about TMS, it's a treatment where magnetic current is delivered to the brain areas that are malfunctioning, and that's why there's the depression. A small magnetic cap is placed on the head, and a little bit of magnetic current is delivered. You barely feel it, you're awake throughout the whole time, and it might feel like a bit of tapping on the head. It's done for several days in a row for several weeks in a row. For moderate or severe depression, I usually recommend both therapy and medication management. But remember, you can always choose not to do one of them if you don't want to. The choice is always yours. To wrap up this video, let's talk about prognosis, which means how likely are you to get better? When using one of the first-line medications we described earlier, about 1/3 of patients get better, 1/3 get better between 2 treatments and 4 treatments, and 1/3 of patients still are not better after 4 treatments. But there is good news. Remember earlier when we talked about rating scales and tracking progress over time, and then it makes you 1.8 times more likely to get back to normal. Well, if we take that not so good number of only 33% of patients who take their first medicine getting back to normal, but we use rating scales, and that's, if you remember, is 1.8 times more likely to get better, then we increase that 33% to 59%. That's almost double the likelihood of getting completely back to normal. So in my practice, I like to stack as many favorable prognostic indicators on top of each other as possible so we can get the best results as quickly as possible. Now, I see this all too often that people with ADHD might fall into a depression because of untreated ADHD. They can't get any work done and they feel bad about it. So if you have ADHD or you're curious about it, head over to this next video to find out how I treat ADHD.